infections. But in Arm A, the prevention and treatment arms, it actually did worse than the prevention-only arm. And there was no significant reduction in infections compared to a standard of care. And I'll say, while I won't talk about it today, there was a third study in Botswana which also used a kitchen sink approach but didn't isolate treatment and also showed incidence reductions, but really including prevention services as well. So what have the investigators been saying? Well, they said there's a lot of in and out migration, there was a lot of late diagnoses and suboptimal retention. But while they note these to be patient-centered interventions, they often talk about them being the general population, given generalized epidemics. And there's really not a lot of study of the individual needs of people within those settings, treating them all as sort of a very homogeneous set of people. I'll say that, this is not just true in trial settings. In Botswana, which is often heralded as a country that has met its treatment targets, we've seen this significant increase from 50% treatment coverage in 2010 to over 90% or about 90% in 2017. Incidence of new infections has been steady at about 18,000 new infections over the last 10 years. So there's been no reduction in new infections in that time frame associated with treatment coverage. And while Botswana is often noted as a generalized epidemic, in fact, there's a really wide range of incidence across the country. There are some settings in Botswana that have very low incidence rates, similar to what we would see in Canada, for example, and there are some places with very high incidence rates. And it starts giving you the impression that people are not all the same, that there is a lot of heterogeneity and differences across the country. The last thing I just want to say is that this is, the disconnect between treatment coverage and new infections is not limited to sub-Saharan Africa. Data that I didn't have time to show today from the United States, from Canada, all say this, that, infections continue even in the context of very high treatment coverage. But interestingly, these are data from the United Kingdom, which for now is the United Kingdom. We'll see in the next year. But nonetheless, you see actually in settings outside of London very similar treatment coverage, high treatment coverage and steady state of new infections over the last 10 years. And only really in London, where there's been this massive prep and testing program, have we actually seen a decline. So further sort of reinforces this disconnect between population treatment coverage and new infections. So then I want to move on to this, why is this the case? And one of these things is really what we've heard about this week about heterogeneity and thinking about the fact that while we often talk about the general population, maybe we should really try and better understand who makes up that population. Here, this is a study that was recently updated by Kate Shannonall in The Lancet, and it looks at the global burden of HIV among sex workers. And what we see and what we know and we've heard this week is that about 1 in 3 sex workers across Southern and Eastern Africa are living with HIV, and that is higher in Southern Africa. But when we look at the mathematical models that estimate sort of what is the relevance or the attributable fraction of sex work within Southern Africa, these are the estimates, and it basically says that about 10 to 15% of the infections are attributable to sex work. So one can understand that if only 10 or 15% of the infections are attributable to sex work, that a country may say, well, we just don't have the bandwidth to cover everybody. So I want to try to explore that because we know that sex workers are so disproportionately affected, but yet these mathematical models tell us that they're not relevant. So I want folks to sort of understand these models. The first thing to sort of keep in mind is that these models use a 1-year time horizon. And I want to sort of pictorially look at why that tells us maybe what explains these results. So on the one side here, you have infections related to serodifferent partnerships. In this hypothetical example, these are wives that may have acquired HIV from their male partners or their husbands. And on the other side, we have, let's say, a sex worker who's acquired HIV from a male client. Well, on the one side, in the context of stable partnerships, there's not a lot of risk of onward HIV transmission among those stable partnerships on the one side. So while over a 1-year time horizon, they look to be more relevant, if we take a longer-term view, we start seeing that it stays about the same. That's very different than sex workers. If we don't meet their treatment needs, they have onward transmission risks to other male clients, who have risks to other sex workers and other partners. And as we start looking over a 5, 10, 20-year time horizon, we start seeing the importance of the few in terms of really understanding transmission more broadly. So how does that play out in terms of a model that looks at this in a different way? Here we're looking, using data from Southern Africa, including Eswatini, Lesotho, and South Africa, looking at the overall infections related to the unsuppressed treatment needs among sex workers and their clients. And over a 1-year time horizon, you can see that the model shows about the same thing, that about 10% of the overall infections are related to the unmet treatment needs among sex workers. But as we look at this over 5, 10, 20 years, we can see that it becomes far more relevant. That as we look at those downstream infections among clients and female partners, about 40% of the infections are attributable to those unmet treatment needs. And it sort of highlights this idea of disentangling what really is the general population. Other data reinforce this as we think about how we can do better moving forward. These are data from Eswatini, and it was a country you heard about earlier this week, formerly called, or many here know, Swaziland. And we can see in the black line there is the status quo, which is a slow but steady decline in numbers of new infections. If we hit, and they've already hit that 90, 90, 90, but not among key populations. Among sex workers, it's about 80, 60, 80. If you just scale up treatment for sex workers and really try to better address their needs and hit 90, 90, 90, you can follow that line down in red, and you see this significant improvement in overall incidence rates over the next 10 years. And it really says that addressing the treatment needs of the few, even in the context of generalized epidemics, is really relevant. So while we often talk about 90, 90, 90 as if it's everybody, actually thinking about who is in that 90, 90, 90 becomes fundamental in terms of overall and even in very generalized epidemic settings. I want to quickly talk about the needs of gay men and other MSM and just sort of make a few key messages. One of those is that as we've looked at these data over the years, whether we're looking at North America or Central and South America or Sub-Saharan Africa, the burden of HIV among MSM is the same. So while we often think of this as something that is a North American or European dynamic, actually there's a remarkable consistency in the burden of HIV among MSM around the world. And I think that makes sense because we don't know that there are any data that there are different numbers of gay men in South Africa versus in Canada. We do know that there's differences in terms of people's feeling safety to come out, in terms of laws that protect people, and in terms of even how people identify. When we think of 90-90-90, the best available data looking at the treatment cascade among MSM is that it's about 25-10-8. And so obviously these huge ways to go in terms of the treatment needs among MSM really across the continent. But again, when we look at those mathematical models, this is all of the countries across Sub-Saharan Africa, and South Africa here is about 4%, says that on a 1-year time horizon, that MSM make up at most about 15% from Kenya overall infections, and just are not deemed as being relevant in epidemics here. So again, we had the opportunity to empirically assess this. This is data from Senegal, a West African country, where we were able to build a mathematical model that really integrated in MSM, both young and old, their male and female partnerships, trans women, sex work. And when we do that, we can see here is this 10-year population attributable fraction, where we look at those downstream infections over a 10-year time horizon from 1995 to 2005 and 2015. And what you see here in the blue box, as well as the purple box, are those infections related to the unmet prevention and treatment needs among MSM to their male partners and also to their female partners. And that actually collectively make up most of the epidemic there. And so again, it sort of talks about really the importance of delineating who is that general population and really better understanding their needs, because it may help you explain away the infections. I want to sort of, have one closing thought around stigma data. And so while I've shown you a lot of data among MSM and sex workers, really there's been very limited collection of stigma data. And we've heard stigma throughout this conference as being fundamental, including from our community speaker this morning. But actually, when it comes to this measurement of stigma, it's pretty rare. There are data from South Africa, across Sub-Saharan Africa, there are data from South Africa, from Kenya and Uganda, but it is remarkably not collected in other settings. So I just want to talk a little bit about what we know about stigma. These are data from a study across the United States in green, and in blue, in countries across West and Central Africa, and in yellow data from Southern Africa among MSM. And when you look at quantitatively, you actually see that there's a far more consistency in terms of how stigma affects gay men around the world than there are differences. And so in terms of being scared to walk in public, being verbally harassed, the trends of stigma are similar. And what we know in higher income settings is that stigma represents absolutely quantitatively the largest fundamental barrier to engaging in PrEP, engaging in treatment. And so while we don't have the same levels of data here, one can show that the trends are likely the same and that the world is probably more similar than it is different. I also quickly want to talk about stigma affecting sex workers. Here, these are data from over 7,000 sex workers across sub-Saharan Africa, including South Africa. And I just want to highlight the remarkable high levels of verbal harassment, of blackmail, of rape or forced sex, of physical violence that affects sex workers across the continent. But from an HIV prevention perspective, I also want to say that the largest predictor of HIV among sex workers is living in settings where sex work is fully criminalized. And so here, after you've adjusted for numbers of sexual partners, condom use, and these things, and all behavioral elements, there's about an 8 times increased risk of living with HIV in the context of sex work, I should say in the context of criminalized settings among sex workers as compared to settings where sex work is decriminalized. And so it just highlights structural determinants as being a fundamental barrier to success. So we've seen this slide already today, HIV pandemic control, and what we see in this red line is following along from 2000 on to 2017, and then we see our goal there, this massive decline in new infections to 500,000 by 2020. And I think that's natural because we've put ourselves in a position where the end of AIDS is common mantra, even amongst the president we all miss. That, the language of the end of AIDS is pervasive throughout, that we can basically not talk about HIV unless we're talking about the end of AIDS. But I'll note that we are now, as of this morning, 200 days from 2020, right? And I think it reinforces the fact that that goal is not going to be achieved. It won't be achieved by 2020, and it's not going to be achieved in the next sort of 10 or 15 years. And we have to think about this long-term and sustained response to HIV as compared to, I think, constantly thinking about the end of AIDS. The last data point I'm going to leave with you is really data from Lesotho. And this is saying, when we have a limited budget, what is the most efficient response moving forward? And in the black line, you see this steady state of new infections, which is indicative of what's happening today. If we take resources away from the needs of the few and just allocate them randomly to all people, irrespective of risk, we actually see increases in HIV incidence. And really, the most efficient mode of responses is one that is very specific and really tries to understand the needs of the different groups that make up the general population and then address those needs with specific programs. So then just a few closing thoughts. One, universal treatment for HIV is absolutely efficacious and effective. It allows people to live normal lives. I can say this as a physician as well. People live normal and healthy lives with HIV. But in terms of reducing incidence, it only does that when we treat people who still have onward HIV transmission risks, which means we have to think about who it is that we're treating if we're trying to also optimize prevention benefits. I think the world is far more similar than it is different. There really are no differences in terms of why people have consensual sex, in terms of procreation or for need or for pleasure. There's also no evidence that there's diversity of sexual orientation, gender identities empirically. So what does it mean to decrease incidence? Well, I think we have to overcome our preconceived notions of HIV epidemiology based on geography and based on culture and context. We have to recognize that, depending on who is in that 10-10-10 or 10-19-27 is probably far more important than the overall number of 10-10-10 and 10-19-27 from an epidemic control perspective. And I think we really need to think better about how we're going to address those most marginalized as a fundamental strategy for HIV epidemic control. So I just want to quickly thank, the studies that I'm presenting today include volunteers who do this at very limited personal benefit and often at great harm. And so I want to thank and those folks and really the community groups that support them and a number of organizations that have helped me develop these messages. Thank you.
Thank you very much, Prof, for a very thought-provoking presentation, and I think it really gives us an enormous amount of information to consider and ponder when we go forward in planning with a diminishing funding an envelope that is coming our way. The next person who needs very little introduction is Dr. Sandile Buthelezi, who will be talking about what our priorities should be. And Dr. Buthelezi is a medical doctor who is the Chief Executive Officer of the South African National AIDS Council and serves as the chair of the Global Fund Country Coordinating Mechanism for South Africa. Please welcome Dr. Buthelezi. Thank you very
much. Thank you, Ashraf, Your Excellency, the Deputy President and the Chair of SANAC, Deputy Ministers, colleagues, friends. My presentation is the last one, and it's always the easy one because I need to try and translate science into the man on the street. On what then? You've had all the good results or the complicated, the professor here just took us through and he's spoken about some of the things that I'm going to talk about. So we just want to try and bring everything down to the man on the street and say, what's next then from here for the country? Firstly, we just need to try and understand what exactly as a country are we trying to do. Of course, the whole issue of prevention is critical for us. How do we ensure that we're now looking further than 1990? The professor has spoken about the importance of key POPs, leaving no one behind. But of course, how do we ensure that we implement behavior change strategies? And critically, later on, the Deputy Minister of Social Development is going to talk about how are we trying to tackle the issue of reducing stigma and discrimination. And what are the main things that we at our level, at the interface of science and communities, what is important that we're trying to do? Of course, promote the promotion of leadership and accountability, focusing for impact, critically ensuring that we're scaling up what is evidence-based, what has been presented throughout this conference. And of course, we really need to ensure that we've got good systems, especially resilient and sustainable systems for health, ensuring that, of course, we've got very good strategic information, quality data, and quality data, which we need for programming and also for seeing how far we're doing and where we're going. And of course, we need resources. It's either we spend now or we spend later. So we rather spend now and save later. Of course, this has been presented in the past few days in terms of the epidemic in the country and the different areas and how they're affected. But critically, you can see in the country that we've got diverse epidemics geographically. And of course, we need to develop responses that are specific to the particular area. Yesterday, HSRC presented very good information. For the first time, they've been able to go into different districts. And you can see if you are in the city of Ekurhuleni, you're sitting at a prevalence of almost 22%. If the city of eThekwini, just under 20%. And you've got your Sibande, also has got its own problems. So what's important for us is that we now need to look at a lower level, not look at a national level, because we want a person who's sitting in eThekwini to know what's important for eThekwini and how do we respond particularly to the problems that are in eThekwini so that we don't have a homogeneous response for the country. Where are we as a country? You know that, again, this was presented, but I would like you to look at that pie chart. What's important there is that more than a third of infections are in a group of 15 to 24 years old. And what's more worrying is that in the same group, actually the females is 3 times higher as compared to the young men. Where are we in terms of the Global Prevention Coalition? Of course, we've had, since 2010, 30% decline in new infections, but you can see how far we are from the target. We've rounded it off to 90%. We've been given an 88% target by December 2020, and you can see by 2017 where we're sitting, we're far from that, and it's going to be very difficult to reach that target, but we need to strive and move forward and do things that are different. But then how do you compare us with other countries? This is a slide that was presented in the GPC meeting in Nairobi, where different countries, the GPC, the Global Prevention Coalition, you can see they're saying if you look at the different paces, of course, no country has already won. That means beyond 75% reduction. But you can see South Africa, they're saying at least we're not staying, we're not walking, we are jogging. That means that we need to really try and join Eswatini, Uganda, and Zimbabwe. I mean, those are all African countries that are running. Eswatini is doing very well. They've just done their SHIMS too, and they're doing very well. And it looks like if they continue and increasing the pace, they're going to be able to reach the winning. Of course, Cambodia, Mongolia, and Nepal, those are almost always almost there in the 75%. So we're not, we don't want to say we're not doing very bad, we're not doing very good, we're in the middle. That means that there's something right that we're doing, so we need to move a bit faster. Where are we in terms of the treatment cascade? If you look at those red dots at the top, Ashraf spoke earlier on, and I think most of the people have spoken about it, that for us to be able to reach 90 targets, we need to put at least 6.1 million people by December 2020 on treatment. So you can see the gap, we're not doing well, especially as you go down the cascades. But there are some areas that are very worrisome. Actually, when we spoke about health system strengthening, if you look between the PLHIV on ART and those that are having viral loads done, that's a problem. That's a health systems issue. Actually, we should be having everyone who's on treatment having their viral load done at 6 months. So that's a problem. Those are the issues that we can work on and see what needs to be done. Though the recent HSRC survey shows that we're doing quite well in terms of the 90, but the numbers that should be there are not actually the numbers that we are expecting that we should be carrying. Of course, where are we when it comes to our social and structural drivers? We just picked one or two indicators. You can see that these are the sexual offenses cases reported 2017-2018 to SAPS. Different provinces, and you can see that in Gauteng and in KwaZulu-Natal and in the Eastern Cape, there's a bit of an increase in that. It's a problem because if we don't address gender-based violence, we will not be able to achieve what we need to achieve. I think the other indicator that we looked at was the indicator of unemployment. We know as a country, critically, if we're looking at the younger group, it's one of the major structural drivers that we're having. And as a country, we're not doing well, but we know there's quite a lot of initiatives led by the president where we're actually trying to address the issues of unemployment in the country, specifically looking at the economically active group that should be employed. And the major worry is also the level of unemployment in graduates. Which is quite a problem for our country. So we really, as government, of course, it's not the main responsibility of government to create employment, but it's to create an environment that is conducive for employment creation by the industries. But success requires deeper and stronger foundations. What are the key issues? And of course, for us, the most important, we really need to build resilient and sustainable systems for health. The integration of the three HIV, TB, and STIs to ensure that we're very efficient. Currently, doing verticalization is actually very inefficient in terms of proper usage of funds. We also need to ensure that we've got stronger systems for procurement and supply of medicines. And of course, this is throughout the value chain. We know that we currently, as a country, we know during the opening this was discussed at length, that we're having some shortages, which some more than of them are not really in the hands of the country, but within the value chain itself. But we need to ensure that that is proper, specifically if you're looking at the number of people that we want to put on treatment. We cannot afford to have pilferages in the system and people are unable to get the treatment. And of course, resources, human resources for health, this is a global issue that we're trying to address. It's very difficult to address. But it's very important, especially looking at health. It's really a labor-intensive kind of an environment, so you need people to do the work. Technology will always be assistive, but will never replace what the people should be doing. Of course, in our investment case and rewrite the different interventions on where we thought we would be if you implement those different interventions. Of course, there are some assumptions. For example, we thought that by now we would have rolled out dolutegravir, and which will be rolling out in the next few months as a country, which is, we're now going to be introducing the integrase inhibitors into our first line, which has mainly been nuke-based. So even then, when we looked at all the scenarios as a country, we still could not, we discovered that the 88,000 that were given, if we implement everything, even with the constraint scenario, we could only reach that by around 2024. So it was really a tall order from the UNAIDS. All the modelers in South Africa were actually arguing, how did we get that on the UNAIDS side? But it's always good to be given tougher targets so that we are able to work harder and harder and harder. So what should our priorities for prevention be? Of course, we all know that the epidemics are different in different pockets of the country. So we really need to apply some differentiated models. You can't have one size fit all. So you need to understand. So for us, what's very critical, Your Excellency, is that the mayor of eThekwini or the mayor of eHlanzeni must understand what's happening there as the leader, because you need to then customize the interventions to fit on what is happening there. But then, critically, one of the key issues, key populations and key populations. This year, one big issue, mainly in Africa and other countries, and also in Eastern Europe and Central Asia, is the issue of human rights. And if these issues are not addressed, the epidemic will keep on going on. So we need to ensure that no one is left behind in terms of programming. Our harm reduction strategies, we really need to fast-track decriminalization in different areas, and of course I'll talk about us as well. Of course, we know that biomedical interventions work. We have a lot of them. If we really optimally utilize them, we can reach somewhere. It's all available. But it means that we're not doing the right thing at the right time. Of course, rolling out of non-biomedical interventions, critically with the demand creation, our Check Impilo campaign, we really need to ensure that we create that demand. And we also ensure that we address issues of substance abuse. It's a critical issue again in South Africa. Of course, we need, as I mentioned, we need to focus for impact. We really need to have locally adapted responses. When it comes to treatment and care, if you look at the people that know their status and those on treatment, that's why we're talking of the 2 million new people. The whole issue of linkages to care, how do we ensure that we build capacity of communities, healthcare workers? Our Welcome Back campaign that we're now moving on critically with the PHIV sector in the forefront and the civil society. How do we ramp that one up so that we ensure that we get as many people uplinked to care as possible? If you test so many people with universal test and treat, we should really be having more people on treatment if you look at our testing numbers. And of course, the retention. We're not doing very well in terms of retaining people in care. What are the issues? How do we ensure that our CCMDD program functions optimally? How do we ensure that we've got proper patient navigation system? Mobile, we've got, almost everyone has got a mobile phone. How do we use that to our advantage to ensure that we follow up people? And of course, adherence support, adherence clubs is one area that has been working. I know there's been a problem with some resources there, but we know that adherence clubs work. So how do we ensure that we actually ramp them up to ensure that people stay on treatment? How do we then, of course, critically, we've got very good, the issue of people who are on treatment and they've not had the viral load done, actually it's saying we're not implementing our own policies. So how do we ensure that our people understand what's our policies and then stick to that and we implement those with fidelity? But also the role of community structures is very critical. Check Impilo campaign, we're ramping up, we're working with sectors, and we think we are actually getting in most of the areas, we're picking up our targets, but key issue is how do we actually integrate that with the healthcare system to get people into care. Of course, when it comes to our social and structural and behavioral drivers, the president has been in the forefront in the whole issue of gender-based violence and the femicide. We really need to ramp them up. And we're all reading the papers, we're all watching the news. It's really horrifying, the stories that we're seeing. How do we ensure that we implement those programs that are actually addressing issues of gender-based violence? Of course, the implementation of the human rights strategy, the Deputy Minister will speak a bit about that later on. Social behavior change campaign, again, the HSRC, they showed us yesterday that it's very useful, actually we get some positives if you actually ramp up your behavior change strategies. Then, obviously, what are our critical enablers that we should be moving on? What should be our priorities? Communities and communities and communities. If we leave the communities behind, we're not going to get anywhere. How do we ensure that the sectors work together? In South Africa, that's why we have the AIDS councils, where we've got different sectors working together. The leadership need to ensure that we bring everyone and we're able to move forward. Utilization of data. Critically, for planning, how do we ensure that we have quality data, we see where we're going, we're able to plan our interventions appropriately, and they are evidence-based. Resources, there's been a lot of talking about resources, and let me say, this country is one of top countries when it comes to domestic resource investment into the HIV epidemic. And of course, we've got PEPFAR investing billions into the program. We've got Global Fund investing billions into the program. We need to invest smartly and actually invest for impact. Because these resources, most of the countries, they can just dream of them. So we really need to think harder in terms of how we ensure this. Revitalization of national communication campaigns. Critically, one of the issues that has been on the radar is the whole issue of the unique patient identifier system. The losing of patients in between facilities, in between provinces. We've got the ID systems, we know that it's got its own limitations, but what's very important is that as a country, we really need to ensure that this gets implemented, because some of the issues is not that people are lost to care. They are probably in care, but they are lost because there is no way to check them in between the facilities. So those are the few things that we thought we should really ramp up in trying in interfacing science with community work. Thank you very much.
Thank you, Dr. Buthelezi. I think that's really a comforting approach to how we manage our epidemic going forward. A lot of work, so don't lose the passion. Be concerned about our complacency. Certainly we are at a critical stage now in the epidemic that we cannot give up. So we are now having a short entertainment break. Afro Dizzy will be giving us a 5-minute action. I'm not sure if they are around. And then after that, I will call on Deputy Minister of Social Development, Hendrita Bogopane Zulu, to talk to the South African National Human Rights Plan and hand it over to the Deputy President. Are they here?
Celebrate good times, come on. Let's celebrate. There's a party going on right here, a celebration to last throughout the years. So bring your good times and your laughter too. We gon' celebrate your party with you. Come on now. Let's all celebrate and have a good time. Celebration. We gon' celebrate and have a good time. It's time to come together. It's up to you. What's your pleasure? Everyone around the world, come on! It's a celebration. Celebrate good times, come on. It's a celebration. Celebrate good times, come on. Yeah.
machozi aje ama nini? Nyie hamialiki, mbona mwenzaka nasema napenda lakini yeye haniambii. Haweza kashindwa kifungo hata 200, ila hanipigii. Hivi sasemi itabidi aongee na mimi, kini hanisikii. Subiri, mimi kweli sitaweza, unanifili kinuwezi kunyonesha. Sasa mimi nikisi unanipenda, hukunambia endo mana nilienda. Hukunambia, hukunambia, nambia, hukunambia, nambia, hukunambia, nambia, hukunambia, hukunambia kwamba wewe unanipenda, hukunambia, hukunambia kwamba wewe utaniweza, hukunambia,
Thank you very much. May I acknowledge the presence of Deputy President Mabuza, the chairperson of the session, Deputy Minister of Health, and all the UN family and all of our distinguished guests. My one is a very simple one. Deputy President, on the first day, as we move the epidemic forward and as we do our commitments, we've launched on your behalf the South Africa's National Human Rights Plan, which is our commitment, because I think the Deputy President have seen that we've done well, but we're jogging, and part of the barriers of why we are jogging is because our stigma and levels are very high. So it does not matter how many people we put on treatment if we are not extending to them that level of, deal with the issues that they face. we are not going to succeed. I'm now going to call upon, it's not every day that I get to call my boss and order him around, but let me enjoy the moment. May I call the Deputy President of the Republic of South Africa to the stage, His Excellency Dep Pres Mabuza. He'll stand right there. And may I please call the leader of the United Nations family to stand next to Dep Pres Mabuza. May I call people living with HIV. I'm getting it right. Yeah, I'm getting very good at it. May I call the chairperson of the conference. People living with HIV. One must come here, please. You know, it's the sector that I know very well, so they know who's the leader. The leader must come up. And I'll do the honors. This is South Africa's commitment, Deputy President, under your leadership, that we commit that we are going to do that which we are required to do to bring the levels of stigma and discrimination so we can reach our NDP goals and get to 90-90-90. Thank you very much. Well, that takes care of, I've done my job. The Deputy President takes it from here. Thank you very much.
Thank you. Thanks very much, Minister Zulu. I'd like to just hand over now to the conference chair, my colleague, Prof. Swana, to talk to read and present the eThekwini Declaration. Thank you very much.
Thank you, Program Director. Shall the Conference Organizing Committee join me up front? Yeah. Honorable Deputy President, Mr. David Mabuza, as well as Chair of the South African National AIDS Council, Deputy Minister Zulu, Deputy Minister Dr. Joe Patla, MECs present here, executive mayors and mayoral committees represented here, representatives from government departments, including Deputy Director Generals and Director Generals, Dr. Jürgen Pillay being among them, Ms. Connie Ngumalo from Department of Science, Social Development, Dr. Mbulawa Mugabe from the UNAIDS, Chief Executive Officer of the South African National AIDS Council, Dr. Buthelezi, delegates, community, all protocol observes, a very beautiful morning to you all. We are here as the organizing committee of this conference to present to the Honorable Deputy President of the Republic what we call the eThekwini Declaration 2019, a radical call to action, reinvigorating and revolutionizing the HIV response. I will give a brief background and then read it, and thereafter I will humbly request the Honorable Deputy President to come and receive the declaration. Honorable Deputy President, in my opening speech on Tuesday, the 11th of June, I said, I hope that by the end of this conference, key messages would be drawn, new directions would have been forged, and South Africa's priorities going forward would have been identified. And the two presenters have addressed that. I also hope that an undertaking to take collective action rather than a divide and rule approach towards epidemic control would have been made. Honorable Deputy President, I stand here to say our wish as the conference organizing committee has come to fruition. In line with this and the ethos of the Rasengwe board, and one of the board members is standing next to me, the board that has been overseeing the South African AIDS conferences for the last 20 years, we have prepared a declaration that affirms our commitment to take the HIV and AIDS agenda forward based on key messages that came out of this conference, which demonstrated the need to strengthen the fight against HIV and AIDS epidemic as it has been eloquently articulated throughout the conference, including this morning. This declaration rebuilds faith in our higher moral purpose of saving lives, and we believe that a good conscience coupled with unity, the right plans and policies can help us to deliver the goal of epidemic control in our country. This declaration, Honorable Deputy President, is a demonstration of the fact that we are united, energized, and determined than ever before to take the epidemic control agenda forward. We, as the delegates of the 9th SA AIDS Conference, we are ready for action. We believe that our people deserve a change. I need to mention up front that further discussions will be needed to domesticate this declaration that I'll be handing to you so that we ensure effective implementation. And at this juncture, I will read out the declaration. I won't read on the big framed, memorable, what shall I call it, portrait in front of me, Honorable Deputy President. I'll just read from my paper. The second Durban Declaration of 2016 affirmed the remarkable progress in response to HIV and AIDS, noting that South Africa remains the epicenter of the epidemic, that the drivers fueling the epidemic still persist, and that not everyone who needs care and treatment is receiving it. There is again a need to revive the sense of agency, political will, compassion, transparency, and accountability towards reinvigoration of the HIV response embedded in human rights principles and ethical values. Investing in HIV is investing in the health, development, and the future of our country. The 2019 SAA's conference confirmed the following, Honorable Deputy President, that about 7.9 million people in South Africa are currently living with HIV, that over 4.4 million people in South Africa are on treatment. Whilst the incidence is declining, new infection among youth, particularly adolescent girls and young women, remain persistently high. Progress towards the 2030 global epidemic control targets is not adequate. This was demonstrated even this morning. Key population and vulnerable groups remain underdiagnosed and undertreated with higher mortality and morbidity rates. The health system is overburdened, resulting in service delivery challenges. We go on to say the response to the epidemic is not yet equal to its magnitude in our country. And in line with this, as the delegates and the leadership of the 9th SA AIDS Conference, we collectively commit to the following principle to take effective epidemic control agenda forward. 1, sustain and strengthen support for unprecedented innovations, technologies, and strategies to control the epidemic as we move into the era of the 4th industrial revolution. 2, strengthen the focus on HIV prevention as a pivotal aspect of epidemic control in continuum with HIV treatment. There's a place for each. Develop, 3, encourage and support active participation of young people in the HIV response for obvious reasons. Address inequalities, including gender inequality, and empower young women and girls. Position the community at the center of epidemic control for a sustained, inclusive, and successful response. Ensure government leadership, and we have seen it this week, ownership and safeguarding of agreed upon country priorities and ethical principles in epidemic control, irrespective of donors changing their funding decisions. Reawaken the urgency of HIV and AIDS as a devastating public health crisis, still requiring an emergency response. Mobilize local and international resources towards epidemic control. Ensure that the HIV and AIDS response is embedded within human rights principles, values, including accountability, transparency, fairness, and justice. Ensure adequate access to ART and other related care. The last 2 bullets: increase efficiencies in the utilization of government HIV resource allocation, and lastly, strengthen health information management systems to allow for better tracking, tracing, and retention of patients for adequate reporting and program accountability. Honorable Deputy President, may I kindly and humbly request that you come forward? It's me.
Okay.
It's me now.
No, I'm going to call the Deputy Minister of Health. Well, thank you, and I'd like to call on the Deputy Minister of Health, Dr. Pachla, to introduce the Deputy President Mabuza to present some concluding remarks on the conference. Thank you.
Thank you very much, Program Director, the Chair of the conference, Professor Refilwe Paswana Mafuya, the Deputy Minister of Social Development, my colleague, Deputy Minister Henrietta Bohupana Zulu, representatives of the eThekwini municipality. I didn't see the acting mayor, MECs who may still be present here. There were quite a few of them on Tuesday when the conference opened, but I suspect due to other duties, many of them may have gone back to their posts. The SANAC board and management, senior officials, distinguished guests, ladies and gentlemen. Mine indeed is a very brief task to do something which I'm sure all of us are looking forward to the address of the Deputy President. But before I do that, let me also, on behalf of our Ministry of Health and Department of Health, congratulate the organizing committee and all the participants for a very magnificent work done over the last 4 days. We were here with the Minister on Tuesday and a number of MECs, as I've indicated, also with my colleague here, Deputy Minister Bohupana Zulu, during the opening. We welcome the declaration which has been presented to the Deputy President. As a major role player in the SANAC, the Department and Ministry of Health is looking forward to the resolutions of this conference and the implementation of those resolutions and also the declaration. Now, coming to my specific task here, the man I'm to introduce actually needs no introduction. I think all of us know Deputy President Dep Mabuza very well. Deputy President Mabuza comes a long way as a servant of the people. He's been involved from his student days in the student movement, in the fight against apartheid, in the mass democratic movement, played roles in various capacities through the education fraternity, but also in the United Democratic Front in the mid and late 80s and the early 90s. So he's been a very key role player in the struggle for liberation. And after the democratic breakthrough in 1994, he was one of the founders of the new democratic government in the province of Mpumalanga, which was then in 1994, just to remind him, we still called it the Eastern Transvaal. At that time, I was part of the Northern Transvaal, and he was part of the Eastern Transvaal. And subsequently, both of our provinces changed their names. Mpumalanga took over from Eastern Transvaal, and Limpopo took over from Northern Transvaal. And I can also just remind him that we had a bit of a tiff at some stage, because there was an area called Bushbuck Ridge, which we had to determine whether it's in the north or in the east. But ultimately that matter was settled. He played a major role in starting in the province of Mpumalanga in various capacities, from the first government under Premier Matthew Posa in 1994, various roles as MEC, including, amongst others, the MEC for Education, in which portfolio we served together for a short time, about 3 years or so. And he took part in various other roles as a member of the Executive Council of the Mpumalanga province. And in 2009, the ANC saw it fit that he had so much experience that he should take over the province of Mpumalanga, became the premier in May 2009, right until when he was elected deputy president of the ANC, and when the new president of the ANC took over in February 2018, he was also appointed the deputy president of the republic. So indeed, a major role player in the struggle for liberation, a key player in the transformation of our society and the creation of the new democratic government, and currently as deputy president, chair of the South African Aids Conference. We welcome Deputy President.
Thank you very much. Program Director, I must thank the Deputy Minister, Pasha, a long-time friend. You forgot to mention that the issue of Bushbuck Ridge, finally, it's in Mpumalanga. Program Director, the Chair of the conference, Professor Refile, the Deputy Ministers that are here, Deputy Minister Patla and Bokhopane Zulu. Thank you for coming. I'm aware that Cabinet is in session. We thank the President for allowing us to be here. All MECs that are here, the leadership of eThekwini Municipality, our diplomats that are here, the SANAC board and management, our government officials, our researchers, our scientists, our guests that are here, and ladies and gentlemen, we could not join you at the opening of the conference due to pressing government business, and we must really apologize for that. It's like something that we did not plan, something that I don't like, coming late all the time. This is the second moment where I come late. You remember the first moment? Remember the first moment? That one. Other moment. And the President even said, we are now all in the house. I came late. However, we are very pleased to be with you at this official closing to reflect on the journey that as a country we've traveled and to share some ideas on what we need to do going forward. The gravity of HIV and AIDS pandemic continues to outlive many South Africans. Many of us would have thought that we have reached the maturation point of HIV epidemic. On the contrary, we all realize and appreciate the magnitude of the task at hand, and we continue to fight. We need to be strong, resilient to fight this virus. We cannot afford to be complacent in our drive to end this epidemic. We must step up our fight and ensure that we implement whatever ideas that will come out of this conference. We need to implement targeted research programs, policy measures, so that we can reverse this pandemic. We are worried about new infections that continue to be on the rise. It is inspiring, though, that this conference has brought together people with knowledge, scientists, researchers, civil society partners, our international partners, and government to reflect, shape, and emerge with new approaches and solutions to the challenges that we're facing as a country. Across the board, there is consensus that something drastic needs to be done. We're encouraged by your efforts and your energy and the willingness to take this journey. As government, we are ready and willing to hold hands with you, to walk every mile in this journey until our total victory. With all hands together on deck, we can stem the tide. Nothing is impossible. It might appear very difficult, but I think we can overcome. The theme of the conference is appropriate in calling for us to innovate and use technology at all levels to bring about sustainable change in our responses to HIV and AIDS. Find new ways of responding. Statistics which were shared by the Human Resource Science Research Council, as well as the University of Cape Town, show us how far we've come as a country in our fight against this epidemic. They equally show the extent of the journey that we've traveled and the journey that we must still travel in order for us to emerge victorious. It appears very difficult. The Tembisa modeling done by the University of Cape Town suggests that there are approximately 7.4 million South Africans who are HIV positive. We are currently having 4.4 million of our people living with HIV that are on treatment. We need to initiate another 2 million to our treatment. This is a very difficult task. It will need all of us to work together consistently and persistently. Never mind the difficulties along the way, so that all these people can be introduced to our treatment. I know the burden, the challenge that is going to be carried by the state. The state is there for the people, and the people are there for the state. Therefore, we must work together to find this 2 million. Whereas our comprehensive HIV response is being hailed as a very good one, what is clear is that we are not doing well in preventing new infections. It's a matter that we need to think about. And we must do something about it. It is estimated that there are almost 250,000 new infections every year, and our target is to eliminate new infections. Is it possible? Yes. To eliminate new infections. The gap is too big, and we must close it. As we make these strides, the contributing factor in not reaching the desired targets remains the challenge of stigma and discrimination. We must take it back to our communities and challenge them. We must challenge our people on this very bad element, that of discriminating people living with HIV and AIDS. Because as I understand it, HIV and AIDS is just a disease. It is a scientific fact that HIV, as well as TB, does not discriminate by age, by race, by gender, by class, or your socio-economic status. We too here must not discriminate on the basis of any of these categories. Instead, we are called upon to value every human being and should at all material times assist those who are infected and affected to overcome their condition in order to reach their full potential. We must be compassionate and ensure that available services are provided with the necessary respect and dignity to all our people. We thank our new Minister of Health for launching the Human Rights Plan on Tuesday. With this plan, it is our commitment as government that every public servant shall provide care with compassion at the highest possible level of quality. Government must try and step up the way we deliver services to our people. This is not only the right thing to do, but a fundamental human right. We are also cognizant of the multiple biological and social factors that play a role in the transmission of this virus. Our learners, especially the adolescents, girls, and young women, will be getting focused attention from government. This entails a holistic approach to sexuality, starting from the age approximately appropriate to life skill education in schools, so that young people have an understanding of their own bodies. We're approaching this work with utmost care and caution so that we do not prematurely sexualize our children. But it's important to gradually gravitate to that point where we talk about these things with our learners, with our young people. In addition, access to dignity PACS is being prioritized by government so that the girl child can be given her dignity. Recently, our government has made all menstrual products VAT-free so that they can be affordable, our people can afford, our young children, young girls can afford to buy these products. We believe that every girl should have the power to decide their future. Our responsibility as government, together with parents, is to ensure that girls are equipped with education in order to lead an independent and a productive life. Our responsibility is to ensure that they are healthy at all material time and that they are safe from any form of abuse and gender-based violence. Empowerment of women is very fundamental to transformation of any society. It has been proven that there is a symbiotic relationship between the levels of societal development and empowerment of girl children and women. It is for these reasons that 3 years ago, as government, we launched the She Conquers campaign. That campaign must be pursued with more vigor in an attempt to try and save our girl children. Equally, we must pay particular attention to young boys to prevent early exposure to HIV and other sexually transmitted infections. Of concern is that the age of the first sexual debut amongst young boys is decreasing, thereby making them more vulnerable to this epidemic. We must ensure that young boys do not become fathers without the necessary planning. Partnership and collaborations are a necessary condition for success in our fight against HIV and AIDS. I'm confident that with this partnership that is displayed here, we are going to succeed. We are grateful to all our partners for their continued commitment and contribution. The overwhelming support that we continue to receive from bilaterals and multilateral partners, in particular PEPFAR, the Global Fund, the German Development Corporation, is highly appreciated and critical to our response to the HIV epidemic. The investment that we continue to make and we are continuing to make every day has not gone unnoticed. In spite of few hurdles along our journey, there is no doubt that we are making progress. It is difficult, but bit by bit, step by step, we are making progress. As a country, we take our leadership in the fight against HIV very serious. Our government, through the South African National AIDS Council, has capable leadership men and women that will continually drive our national response. We're calling on all our people to join this journey. In the process, we must ensure that the flow of donor funding is sustainable, prudently deployed, and effectively spent and accounted for. We must account for every money that we use. We must use our money sparingly and correctly. At the highest leadership level, we'll continue to ensure that we provide leadership and support the work of SANAC. I'm back again as chair of SANAC. I'm back. We acknowledge the advice from our experts that our focus should be on the delivery and implementation of programs at the local and district levels. That is why our provincial and our district AIDS council must be strengthened. All our premiers and mayors will be held accountable for the performance of their AIDS councils in provinces and municipalities where they lead. We are pleased that there are sub-districts that are showing good performance, and this good performance must be replicated in many areas of our response. We are happy that this conference has shared lessons and practical models that work in enhancing our HIV and AIDS response. These modeled interventions seem to produce, in some instances, desired results in different parts of our country. Our task going forward is to ensure that those identified interventions are replicated and upscaled for maximum impact. On our past, as government, we'll focus on gaps that have been highlighted in respect of drug shortages in different health facilities. The Minister of Health has prioritized this matter. The sixth administration will not allow a situation where people's lives are put at risk because of drug supply and the shortage of drugs in our facilities. This conference has provided an opportunity for all voices to be heard, especially those in frontline services. These voices must guide and shape our collective response as a nation and the world. Our collective responsibility is to foster the unity of purpose in our response to the negative social impact of HIV and ensure that our collective energies and resources are consolidated to achieve the outcome that we all desire. We pay special tribute to all those amongst you who have dedicated their time in the course of their lives to contribute to the national effort of reversing the spread of HIV and AIDS. We would like to thank the leadership of civil society, our scientists, our researchers, our professors, business leaders, and individuals from across the length and breadth of our country and the globe for lending a hand and making a difference. There are many others that are doing important work in our communities. We wish to salute them and encourage them to continue with their good work. To the conference organizing committee under the leadership of Professor Paswan Mafuya, we thank you for putting together this very important conference and making us proud as a country. On behalf of government and SANAC, we commit to taking forward the recommendations that came from this conference so that we meet in 2 years' time where we can see a quantum leap in our country's response to HIV and AIDS, including meeting the targets that we have set for ourselves for December 2020. We're going to put in good use the resolutions and the ideas that you have collated in this conference. This conference was very useful in our journey of fighting this epidemic. This time that you have spent here was not wasted. The food that you have been eating was not wasted. Thank you very much. Thank you.
Thank you for the keynote address by Deputy President Mabuza. Really inspirational words, encouraging us to continue the work, focusing on addressing stigma and discrimination, certainly not losing the focus on prevention, working on quality of care, and also ensuring health system strengthening, community system strengthening, and individual system strengthening continues. So in closing, I'd like to call Professor Paswana Mafuya to give us a few closing remarks on the conference, and then the conference will be closed. Thank you.